Good afternoon, everybody. I am Dr. Gorika, your coordinator of the session. We are just waiting for Dr. Dibos Mehta. She's joining us soon. She's a participant with us. Just give us one more minute, please. Good afternoon, everybody. Am I audible to everybody?
Yes, yes, yes.
Okay, अभी मेरा मास्क tinted आ रहा है. I, Dr. Gorika Saxena, welcome you all for the first session of poster presentation task. We have a list of participants with us. Dr. Desham, you're here. Dr. Desham, kindly unmute yourself.
Hello, ma'am. Am I audible?
Yeah, you are. Dr. Neha,
Yes, ma'am.
Dr. Manish,
Yes, ma'am.
Dr. Dibos Mehta.
Yes, ma'am.
So the session is being chaired by great eminent us, Dr. Ashok Kumar Srivastav sir is with us, Dr. Snehal Amita Rajamurthy sir is with us, and Dr. Manya Prasad ma'am is with us. So I'll be starting the session, and all the chairpersons will be sent a Google link so that they can mark the respective person, and every person who's all the participants are requested to take the registration name so that accordingly they can be marked. I hope I'm clear. You all have been given a registration ID. You have to use that before you start the presentation so that it will be easy for the chairpersons to judge. So I am the course, I am your coordinator. I'm Dr. Gorika Saxena. I'm currently pursuing MPS from AIMS Rishikesh. I was practicing as an implantologist at Gusar National University. And the great personalities that we have is Dr. Ashok Srivastav sir, is a professor at Department of Community and Family Medicine, Dehradun. He has great interest in epidemiology, basic and applied in biostats, and he has been a great pillar to the Department of Public Health. Next, we have is the eminent Rajamurthy sir with us, currently working as an additional professor at the Department of Epidemiology at Nimrans, and is coordinating the MPH course and the epidemiology module. We welcome you, sir. And last but not the least, we have Dr. Manya Prasad ma'am with us. She's working as an assistant professor in NDMC, New Delhi. Ma'am, we welcome you.
Thank you. Thank you.
So, are we, so, ma'am, sir, should we start with the session?
Yes, please go ahead.
Yeah, you please go ahead.
Thank you, ma'am. So, I would request Dr. Disham, please share your screen. Go ahead. Dr. Dish?
Desham, ma'am,
Disham, yeah.
are you able to see my screen, ma'am?
Yes, we can. Please. You will be you have been allotted 5 minutes, ma'am.
Okay, ma'am.
So I would request you to conclude accordingly.
Good afternoon, everyone. I'm Dr. Desham. I'm from All India Institute of Medical Sciences, Mangalgiri, Andhra Pradesh. I'm working as senior resident in Department of Community Medicine. Today, I'm going to talk about barriers and facilitators in breastfeeding, perspectives of working women in healthcare sector. Uh, Nurses and midwives are the first level care providers for most women across the world. They provide support to women starting from family planning to breastfeeding guidance, delivery, and post delivery assistance. In this dependent environment, women have also been misguided by the health workers in terms of breastfeeding and infant feeding practices. Increased workload, shortage, and lack of training opportunities have been attributed to gaps in quality breastfeeding support services. The objective of this study was to explore the challenges faced by working women in healthcare sector and also to find out the possible solutions for conducive workplace environments. This was essentially supposed to be a bottom-up approach. The methodology we used was qualitative study design, and there were three focus group discussions used. The participants were divided into three groups. The first focus group discussion was with nursing staff, and the second one was with nursing orderly as well as ANS, and the third one was with housekeeping staff. This was conducted in our own institute, and then the sessions were audio recorded and were transcribed. I was the facilitator, whereas there was another recorder for the session. The results were divided into four themes depending on the observations that we got from the FGD. The thing which I would like to stress here is the workplace environment as well as the suggestions given by the participants. The workplace environment, we got the barriers as the night shifts or the emergency duties or the stressful work as one of the most important barrier for breastfeeding, and the lack of emotional and moral support from the colleagues, and long transit times to reach the workplace, and lack of creches at the workplace. The facilitators for breastfeeding were the paid leave policies, clean and lubricated creche, experienced caretaker, attached toilet to the creche, toys, cradles, and lockers inside the creche. Residence in the campus or near to the workplace was considered one of the most important facilitator, and also the awareness sessions for breastfeeding was also considered as a facilitator. Some of the quotes which I'd like to specify from the discussions were one of the participants said that there will be no impurities in mother's milk, it will be very pure, and we need not we need not boil it or sterilize it. Bottle feeding is harmful to the child, but every mother has a bottle in her bag. And then reflexes in a working woman are very less compared to the non-working woman. So milk production will be less compared to the woman at home. One woman told that I had lumps and painful breasts. I had to work from morning till evening from third month after delivery. One woman told that I wasn't allowed to bath for 21 days after delivery to help faster healing of sutures. And there was actually a bit of a confusion regarding bathing times, like they were not allowed to take bath from 3 days to 21 days, depending upon the family circumstances. Here are the two photographs, which one photograph is related to the FGD conducted in housekeeping staff, and the other one which I'd be telling at the end. Suggestions were divided into four levels. One is at the individual and family level. They were expecting support from the spouse in baby care, mother's nutrition, sexual health, and well-being, allowing mother to rest while not breastfeeding, and friends to support and act as stress relievers. At the institute level, they wanted a uniform paid maternity leave policy, support from colleagues, breastfeeding corners, and breast milk storage facilities. They also wanted a flexible work timing for breastfeeding women. At community level, the suggestions were improved awareness on the essence of breastfeeding, and not considering breastfeeding at public places as taboo, and providing privacy to the mother while feeding the child. One of the women told that in Western countries, mothers do not feel embarrassed to breastfeed in public places. There is so much awareness among the public. And at the policy making level, they were wanting to enforce the paid maternity leaves in all the sectors, breastfeeding corners in railway stations and bus stands, using self-help groups and Anganwadi workers for raising awareness, and introducing breastfeeding as health education topic in high school curriculum was one of the most important suggestions that was given by the women who were working, that is housekeeping staff. The reason they told were that the girl children will be educated at least up till 8th to 10th class, and if they are given sufficient knowledge in their high school education, then they will be more willing to breastfeed in their future life. This was what the suggestion was given by the participants. Thank you very much for giving me this opportunity.
Thank you, Dr. Your registration number is 151, and we have sent a Google link to all the respective judges. They can mark her with the registration number through that, and the results will be saved in the Google Drive with us.
Okay, ma'am. Thank you.
Accordingly, reply back who is the winner of the session. So, should we move for the next poster, sir, ma'am?
Yes, I think so. Yeah.
Thank you, ma'am. So, Dr. Neha, please.
Yes, ma'am.
Dr. Deesh, kindly mute yourself.
Yes, ma'am.
And stop sharing your screen as well. Sir and ma'am, the Google links have been sent to you through WhatsApp and your emails.
Yes, I saw the link. Could you please just repeat the registration number of the first
Ma'am,
presenter?
151.
Okay, thank you.
Dr. Please share your screen. We're running out of time. Dr. Neha, can you hear me?
Yeah. Yeah, I can hear, but I'm not getting the option to share the screen.
Look at your screen downstairs. There's an option of share screen just next to chat.
Yeah. Good afternoon, everyone. I'm Dr. Neha Clare from Department of Community Medicine, GMC Patiala. My topic for today's presentation is study on anthropometric and socio-demographic profile of under 5 children in urban slum Patiala city. Introduction: children under 5 years form the most vulnerable segment, and the nutritional status of these children is a sensitive indicator of the community health. Malnutrition among under 5 children is a major public health problem in India. As per NFHS 4 2015-16, stunting, underweight, wasting among children under 5 is 38.4%, 35.7%, and 21%. There are 13.7 million slum households in India. The prevalence of undernutrition in urban slum is much higher than the national average for the rural and the urban areas. So the following study among under 5 children was undertaken. Objectives: first is to study the socio-demographic profile of under 5 children. Second one was to assess the nutritional status of under 5 children using anthropometric measurement. Methodology: a community-based cross-sectional study was conducted in under 5 children living in urban slum of Patiala city in the year 2019. During this time period, house-to-house survey was done, and total of 350 children were included in the study. The socio-demographic data was collected by interviewing mother and or the guardian of the child using semi-structured structured questionnaire, and the anthropometric measurements were recorded. Inclusion criteria were the eldest among under 5 children in the house was included. Then those children whose mother agreed to participate in the study were included. Exclusion criteria was those children who were unavailable during the visit. The result of this study was, first is socio-demographic profile. Out of 350 children, 180 were the female and 170 were the male. According to age group, out of 350 children, 65 children, that is 18.75% were of the age group less than 1 year. Then 200, that is 57.14% were of the age group 1 to 3 years. Then 85, that is 24.29% were of the age group 4 to 5 years. According to socioeconomic status, out of 350 children, 27, that is 7.71% belong to lower class, and then 234 children, that is 66.86% belong to the upper lower class. Then out of 350, 89, that is 25.43% belong to the lower middle class and the above classes. And this classification was according to the modified Kupuswamy scale. Then the type of family, out of 350 children, 180, that is 51.43% belong to joint family. Then 119, that is 34% belong to the nuclear family, and 51, that is 14.57% belong to the three generation family. Then distribution of children as per nutritional indicators. Out of 350 children, 55, that is 15.71% were underweight, 63, that is 18% were stunted, and 43, that is 13.42% were wasted. And then age and sex-wise distribution of under 5 children, less than 1 years, total were 65, that is 18.57%, and in age group of 1 to 3 years, 200, that is 57.14%, and in the age group of 4 to 5 were 85, that is 24.29%. Next is a graph showing the age-wise distribution of children, and then is distribution of under 5 children according to their family type. Here, the maximum children belong to the joint family. Next is a discussion. The result of this study are similar to the study by Gautam et al., in which 48.46% were male and 51.53% were the female. And the minimum number of the subject, that is 10.77%, were in the age group of 0 to 12 months. Even in our study, the minimum number of the children were in the age group of less than 1 year. The result of the present study was concordant to that of the study by Yadav et al. And Gautam et al., where the maximum study subject belonged to the socioeconomic class 4. And even in our study, the maximum children belong to the socioeconomic class 4. In the study done by Deshpande et al., maximum number of children belong to the joint families, which was similar to the present study. The findings of the present study were similar to the study done by Joshi et al. And Jadhav et al., where the underweight were higher among females than the male. In the study done by Malover et al., females were more stunted as compared to the male, and in the study done by Gautam et al., wasting was found to be more among the males than females, which is similar to the present study. The overall prevalence of underweight, stunting, and wasting in the present study was lesser than that reported by NFHS for India. Conclusion, it was seen that underweight and stunting was more prevalent among the females than in the male, which show that there is a need to promote the gender equality.
Thank you, Dr. Neha. Uh, I would request ma'am and sir to please mark Dr. Neha. Her registration ID is 139. Am I audible?
Yeah, but I have not received the form yet.
Sir, we have mailed you the form, sir.
Mm,
We have WhatsApped you also.
Okay, I will just go through it.
It's a Google form, sir.
Right.
So should we move for the next presentation, sir?
Yeah.
I would request Dr. Dibosmita to please share the screen and proceed.
Hello, the screen sharing is showing failed to start. I'm trying. One second. Screen sharing has failed to start. Please, error code 105035.
Dr. Debosmita, kindly check the screen. There is an option of share screen.
Yes, I am doing that.
Just select the poster screen.
It's showing screen sharing has failed to start. Please try again later. Please, one second. I have my technical person right here.
It's okay. If you want, we'll share your presentation from here.
Give me just 10 seconds and then I'll tell you. I think you will have to share it. It's showing some error code here.
Dr.
Dr.
Debosmita, I'm
I can just suggest something. Probably she can mail you her poster.
I have all the
Yeah.
yeah, I have all the posters, ma'am. I'm
Can I
just
mail it now?
screen sharing yours.
Can I mail this one, please?
So
Dr.
meanwhile, maybe
Debosmita,
the next person who's ready can start presenting. She can
Yes,
mail
yes.
you the
I have
PPT.
already mailed you.
I'm opening it. I'm sharing my screen. I've opened your
Okay, great.
poster. I'm just sharing the
So,
screen.
can you just open the one I have just sent you? I've just sent it to Eficon Rishikesh just now.
I would request Dr. Debosmita to please wait for a moment. I would request the next participant is Dr. Manish Bhatt ready. Is it possible for you to present?
Yes, ma'am, I am ready.
All right. So I would request Dr. Manish Bhatt to be present by the time Dr. Debosmita. I'll check it.
Yes,
Okay,
thank
ma'am.
you.
And his Dr. Manish Bhatt's registration is 40. Can we proceed, Mane ma'am and Ashok sir and Rajamurthy sir?
Yes.
Yeah, yeah, start.
Thank you, ma'am. Thank you, sir. Am I visible, sir?
Yes.
A very good afternoon to all respected teachers and everyone who are presenting here. And I'm presenting my poster on the topic of breastfeeding practices pattern in Haldwani block, Uttarakhand. First of all, I want to introduce myself. I'm Dr. Manish Bhatt, postgraduate resident, third year from the Department of Community Medicine, Government Medical College, Haldwani. As we are starting as an introduction, the breastfeeding is the most important means of providing infants with nutrients for healthy growth and development. Exclusive breastfeeding is the method of feeding where infant receive no liquid or solid feed apart from the mother's milk right from the birth up to the 6 month of age. And what is the identification of need for this study? And only 41.6% of babies are breastfeeded with an hour of being born. It is set by the UNICEF. And the National Family Health Survey data indicates that 54.9% children are exclusively breastfeeded, and exclusively breastfeeding is on average for 2.9 months only. And the objectives for this study was to determine the breastfeeding practices pattern in Haldwani block, Uttarakhand. And the rationale for this study as infant as susceptible to various communicable and nutrition related diseases affecting the growth and development of infant. Mother must be made aware of the importance for proper breastfeeding. So we want to check uh, the knowledge of the correct breastfeeding practices. And the research question was the what are the breastfeeding practices pattern in Haldwani block? And we are next section was methodology. The study design was the community-based cross-sectional study, and the study period about the 6 months. And the study population was the age between the 0 to 23 months of the children. And the study area was urban health training center and rural health training center area of the Department of Community Medicine, Government Medical College, Haldwani, Uttarakhand. The sample was 280, but we have taken only 129 for this study. We have taken just 0 to 6 month children for current study. And the data collection technique was the face-to-face interview of the mothers. And the now we are discussing about the results. The age of the mother was 26.91 years, and 4.38 standard deviation. Now we are just focusing on results. The mean age of the mothers was 26.9 years and plus minus 4.38 standard deviation, mean plus standard deviation. And the 58 means 45% of the participants were belong to the family having the less than 5,000 rupees income per month, and the 46.5% participants were belong to the family having the 5,000 to 10,000 rupees income per month. And if you talk about the education of the mother, the 67, that is the 52% of the mother were graduated, followed by the intermediate pass 16.2%, and the followed by the illiterate about the 8.5%, and the last 7.7% had completed their high school. If you talk about the breastfeeding practices, the prevalence of exclusive breastfeeding was 45.7%, and the prevalence of almost 50% of the children for birth. If you talk about the birth order, the 50% of the children have the birth order was first, and we have take the association of early initiation of breastfeeding with the child characteristic like children's sex, birth order were not significantly associated, and but the association of exclusive breastfeeding with mother's characteristic like mode of delivery, normal and cesarean, and mother's education was found significantly associated. So the conclusion, the breastfeeding practice of the women need further improvement. Health education and health promotion program regarding breastfeeding practices should be constituted effectively and appropriately to improve effective feeding. Since the study shows the education status of the mothers to be positively affecting breastfeeding practices, education to the females must be promoted. Thank you. Thank you, sir.
Thank you, Dr. Manish.
Thank you, ma'am.
We are sharing Dr. Devosmita's poster, ma'am. Dr. Devosmita, are you ready?
Yes, I'm ready.
Is my screen visible?
Yes, it is visible.
Yeah. Please.
Let's start.
Yeah.
Thank you, Dr. Saxena. Good afternoon, everyone. I'm Dr. Devoshmita Paul, Scientist C in MRHRU Tripura. It's a DHR unit. So the topic is anemia in pregnancy and compliance to iron folic acid supplementation, a cross-sectional study from Tripura. As we know, India has the highest anemia prevalence among pregnant women of entire South Asian belt and also worldwide. 57.45% incidence among the ethnic women of Tripura. They have anemia during pregnancy. Anemia causes up to 40% of maternal perinatal mortality worldwide and is the leading cause of perinatal infant mortality also, and also of low birth weight. So our study was aimed at determining the prevalence of anemia along with the compliance to the iron folic acid supplementation program among the pregnant women of rural Tripura. So the methodology, it is a cross-sectional study conducted from December 2015 to December 2016, 1 year duration. It is a two-stage stratified random sampling employed in 2 rural community development blocks. 10 villages were enrolled and total 233 pregnant women were recruited. It's a pre-designed questionnaire with socio-demographic details were filled up after obtaining informed consent. And the determination of hemoglobin level was conducted by Cyan-Met hemoglobin method. The frequency distribution chi-square test were applied for analysis. The results that we came to were the mean age of the group was 23.06. The prevalence of anemia was mild. A mild anemia was seen in 54.8%. Mild, that is 9 to 10.9 gram per deciliter hemoglobin. Moderate, that is 7 to 8.9 gram per deciliter, was found in 25.2%, and 20% women had hemoglobin within the normal level. The mild and moderate anemia, that is 66% of the population showed, and moderate 70.2% showed higher association in first trimester of pregnancy. In case of the mild anemia, 66%, and in case of the moderate anemia, 70%, they showed in the first trimester of pregnancy compared to the second trimester. So in the graph here in figure 2, you can see that we have given that in the first and second trimester we have shown. In the first trimester, if you can see the bar diagram, in this we have shown that in the first trimester, mild, moderate, both the anemia, they are comparatively higher as compared to the second trimester.
2 minutes left, Dr. Debosmita.
Yes, then we came to the iron folic acid supplementation. We found that majority, that is 84.1, adhered to the recommended dose. 20% were non-compliant, out of which 15.9% did not initiate, citing did not feel the need, and other 30.6 and other non-specific reasons in case of 19.4%. A staggering 50%, as you can see in the pie diagram, were not able to provide a reason for non-initiation. So from this study, we could conclude that according to WHO, in second trimester, there is a high rate of anemia. But in our study, we found that it was opposite. So we could say that the ongoing interventions seem to be working in the state of Tripura. However, an universal coverage must be pursued. Early sensitization among women with low education, adolescents, and women of reproductive age in general is recommended, and awareness and surveillance to achieve an increase in maternal health service utilization at an early stage of gestation needs to be established with immediate effect in the state of Tripura. Thank you.
Thank you, Dr. Debosmita. And 97 is her registration number. I hope I'm audible.
Yes.
Yeah. So I would request Ashok sir, Rajamurthy sir, and Manya ma'am. The floor is open for questions. You can ask questions to any of the participants regarding their posters.
All the participants has presented.
Yes, sir. Dr. Samar and Dr. Ekta will not be able to join the session due to some unavoidable circumstances.
All right. Can we have the posters again in front of us?
Yes, sir. So should I start one by one, sir?
Yeah.
Yeah. So Dr. Dinesh.
Yes, ma'am. Ma'am, are you able to see my presentation, ma'am?
Yes.
Okay.
Okay, Dr. Disam.
Yes, sir.
Yeah. In your barrier, you have mentioned that night duty, shift or emergency duty or stressful work, lack
Yes,
of moral, emotional support from colleagues. But suggestion you are incorporating individual and family level. But in the barrier, you have not mentioned all these things. So why are you giving suggestions? First of all, at individual and family level.
Sir, actually, the whole idea of this exercise was to find out the perspectives of working women, like what are the perspectives of them, to encourage them to breastfeed, exclusively breastfeed the women. So actually, the barriers and facilitators were found at the institute level for us to develop our institute to make it breastfeeding friendly. So that we have kept workplace environment as a separate theme that emerged as a separate theme. But when we asked suggestions by the participants, they came up with different kinds of suggestions, and then we were like, we thought that we need to keep them under 4 different themes. Like otherwise, it would be incomplete. The suggestions by the participants will be incomplete if we only concentrate on the institute level. So that was what we felt, sir.
Okay. Another thing I would like to about the educational status of these mothers, because you have taken housekeeping staff, nursing,
Yes, there were
and nursing staff. So different age groups are different, but you have not commented anything on the age groups.
age groups were actually between 30 to 40 years only, sir, and the mean age was 33.3 years.
And education.
So educational level is different, sir, because there were 3 levels of participants involved. One is nursing staff, that is all the nursing officers, like 8 of the
And
nursing officers.
that is clear, but
Yes, sir.
you have not mentioned.
Nursing orderly and ANMs were of the lower level. They had minimum of 10th class passed, and housekeeping staff were some of them were illiterate and some of them were like 4th or 5th class passed, sir.
So do you think this may act as some of them as a factors covariate?
Yes, sir, it might act, but as this is a qualitative study, we have kept the 3 groups separately. Like nursing staff, we have conducted separate FGD, and housekeeping staff separate FGD. So we have come up with various levels of interventions that we can do at various levels, sir.
But you have pulled all the data, no?
Yes, sir. Yes, sir. We have pulled all the 3 data. We have actually entered the data in Atlas TI, and then we have coded them. We have actually given separate themes for all the codes, and then we have again discussed with the recorder as well, whoever was present with me. And then we have come to the conclusion, sir. And we also actually suggested to our institute that this kind of suggestions were given by the participants. So there was an attempt to get something out of this study. So we also installed a kiosk over there, breastfeeding kiosk in our OPDs. 2 kiosks were installed after this study, sir, to encourage the breastfeeding.
I have one question, Desham.
Yes, ma'am.
So, of course, you conducted 3 FGDs. I'm assuming so that there's homogeneity in the kind of participants that you included within
Yes.
each focus group discussion. So, as you said, they're distinct in terms of their socioeconomic status, educational level, and so on. So,
Yes,
I'm
ma'am.
just wondering, did you find any distinction in the barriers and facilitators amongst these 3 groups of women, seeing that they are quite distinct in terms of a number of things that are probably determinants of
Ma'am,
facilitators and barriers. Yeah.
yes, ma'am. Actually, we have found out that nursing staff were permanent staff over here, ma'am, and the others were contractual employees. So the contractual employees were more talking about their previous employments where they were not given enough leaves or enough, facility for their breastfeeding their children. Whereas nursing staff were more concentrating on the providing creches in the institute, whereas this nursing orderly and housekeeping staff were more concentrating on the paid salaries that they should get when they are in maternity leave, because they were not getting any paid salary when they are in leave. So that was what we found as a main barrier in both the cases, ma'am.
Okay, good. Thank you.
Thank you, Dr. Desham, for your presentations. I just have 3 queries. My
Yes,
first query is, what kind of approach you applied for a qualitative analysis? Is it deductive or inductive?
So we actually have taken both the approaches. So first we have inductive approach, in which we have formed our FGD guide. There were certain questions which we wanted to ask, like what are the things that you expect from the employee, from the employer, and then what are the things that you expect from an institute, from the colleagues. Like there were certain framework that we have thought earlier, So it was an inductive, but then later on when we got the suggestions, as well as we have got several cultural misconceptions and gender disparity, these were all the themes which were emerged from the FGD itself. We did not ask that question. So it's kind of both inductive as well as deductive, I can say.
Okay. Do you think that your 3 FGDs is sufficient for you to have a good interpretation about the barriers and facilitators for breastfeeding in your study?
So for the objective of this study, this was to develop our institutional this thing. So we thought that our objective was met with the third FGD. Like, we were not getting any new ideas or newer barriers or newer facilitators. So we have stopped the study with the third FGD, as well as the number of groups was very limited. Like the female number of working groups, we have taken all the levels. So I thought that this would be sufficient, sir.
So do you have any specific reasons why you didn't include the doctor professionals in your study?
There were very less female doctors working in our institute, sir, who were actually married and had a child already. So we thought that nursing staff would be better.
Okay. Finally, one question is, what do you think are the implications of your study to your institute, or basically you did it in your institute, no? So what are the implications that you have from your study?
One very important thing that we noticed were the participants told that they need a separate place for breastfeeding. So we actually had a breastfeeding corner in our institute, but which was not very private for mother, and people cannot actually find it out unless they go somewhere and ask the registration desk, where can I breastfeed? So this was what came up as a kiosk, where we have actually asked a Rotary Club people to donate, if they can, a kiosk, so that it will be visible to everyone. So this one, and then they also mentioned about the breastfeeding awareness sessions. They asked us to conduct some awareness sessions. So we thought that every breastfeeding week, every year, August 1st, we can take up the awareness sessions to the people who are working in the institute, sir.
Thank you, Desham. Just one out of interest, you can just look into how some of the barriers have converted into facilitators because of your interventions. Can be a future course of study that you can look into. And thank you for your presentation.
Yes, thank you very much, sir.
Thank you.
Thank you, Dr. Desham. So, ma'am, sir, should we move to Dr. Neha?
Yeah.
Dr. Neha, please share your screen.
Yes, ma'am. Shared, ma'am.
Yeah, Dr. Neha, why did you use Kuppuswamy method for assessing the socioeconomic status?
Sir, this was a urban slum. So mostly in the urban areas, we are using Kupuswamy scale for knowing the socioeconomic status.
Does NFHS data support this method?
Sir, since it was in urban area, therefore I have used this Kupuswamy scale. Otherwise,
you have taken malnutrition from NFHS data, na, 2015-16.
Yes, sir.
And so the stunting, mud wasting as this much. So did they use a Kupuswamy method for assessing the socioeconomic status?
Sir, I don't know about this.
Are these children registered with Anganwadi?
Sir, no, this was like urban slum, and we did house to house survey, and so among these children were registered in the Anganwadi center, but not all of them.
So were they getting all the facilities of ICDS?
No, sir, not all. Some days they said that Anganwadi was closed, and some day they said they before like after going, they say the material is over, they have already distributed. So some of mothers do complain about this issue now.
What recommendation you have already said that underweight and stunting are more frequent among females,
Yes, sir.
and you should promote gender equality. So what made
Yes,
you
sir.
suggest this?
Sir, like
What made you
there
suggest
is
this?
all sir, I like there is a program Beti Bachao Beti Padhao Yojana, under which there is a greater enroll, which is to promote the uh, girl child, their safety, their health issues. Moreover, they want that there should be greater registration of the children, child in the schools, and uh, then there is a Ujjwala scheme also to protect the children from trafficking, and
I am talking
this
about the
was it.
conclusion that you made.
Yes, sir. Means there should. I have talked to ASHA workers also, and I asked them that they should promote the that more number of the female child should be enrolled in their Anganwadis.
What is the sex ratio there?
Uh, sir, I don't know.
Okay, thank you.
We have time for another question, Gorika. Should we move on?
Yes, ma'am, you can.
Okay, so just a quick question, Neha. So in epidemiology, there's a famous hypothesis that links socioeconomic status and nutritional status later on in life. So how is socioeconomic status linked with the development of metabolic syndrome later in life?
Ma'am, it has been seen that those children who are malnourished, they are more prone to get diabetes. And
What is this hypothesis called? So you're saying that children who are malnourished, suffered malnutrition in utero, later on in life have an increased propensity to develop metabolic syndrome. Is that what you're saying? And what is the name of this hypothesis?
yes, ma'am. Sorry, ma'am.
Okay, it's called Barker's hypothesis. Okay, thank you.
I have one more question, Dr. Neha. Thank you for your presentations. How did you make the anthropometric assessments in your study, and how it was standardized?
Sir, I used measuring tape for taking for recording the height of the children, and in the child less than 2 years of age, we were recording the length. And for that, the child was made to stand against the wall with his shoulder and the heel of his feet
You
to
followed
touch
some
the back.
methodology. So you are the one who took the measurements, or there were some other people who are involved in
So
taking the
actually, this
measurements?
was a part of my thesis. So I and one more intern used to go, and we used to take the anthropometric measurements.
So how did you taken care of the inter-observer variations? Hello?
Hello, yes, sir.
How did you taken care of inter-observer variations in your measurements?
Sir, please repeat.
How did you address the inter-observer variations in your study when more than one people was employed in measuring the anthropometric measurements in your survey? So how that inter-observer variation was taken care of in your
Sir,
study?
I used to go once in a week. So before going, the intern, whosoever was posted in our department, one of that intern, I used to tell them how to take the measurement. And moreover, it wasn't like for take. We used to go together. So I used to stand and see how they are taking. If there is any problem, then I used to take it by myself, and he or she used to collect the data. Otherwise, measurement part was done by me.
Okay, thank you.
Thank you, sir.
Any more questions? Should we move to Dr. Debosmita?
Yeah.
I'm sharing a question. Is it visible? Hello?
Yeah.
Dr. Debosmita, are you here for the session?
Yes, I'm here.
Dr. Devasmita, how did you arrive at this sample size?
This was done by just like random I mean, it was so actually I am scientist C with MRHRD and I am basically a microbiologist and we have a statistician. So for the sample size deduction, we actually did it by the process and arrived at 233. So I won't be able to give you details on the sample size and incidence actually. But it has been done by method. I can assure you of that.
Okay. You are saying that the study was done way back in 2015-16.
So 2015-16, but it is the part of a much larger study and it is the first of its kind because Tripura, as you know, the population that you are seeing here, it's one of the remotest you can imagine. It's a ethnic population of the Tripuri tribe who few years back had hardly any association with any kind of antenatal checkups maybe. So this we went inside and reached them in a very remote, these villages are quite remote. So this is wow, there were some positives and negative point and so this study it is part of a much larger study actually. Hello.
Yeah,
Okay.
actually, you have you have mentioned everything that early sensitization with low education, adolescent and women of it is general recommendation or your some specific recommendation?
So recommendation as in
You are just giving generalized statement or did you have
association with what, sir? Education? I
you have
did not give an
you are telling in a generalized statement that early sensitization among women with low education, adolescent and women for reproductive health is
Oh, okay.
recommended.
Early sensitization among women with low education. Yes, yes. We did do the educational. I mean, there was in the demographic data. We also had the educational status. So there was a very great lack of education. I mean, you cannot even imagine high school education in this population. We only got maximum till the fifth and sixth standard education. So early sensitization among women with low education, and also we saw that the women who had even less education, like the illiterates
And,
or
now,
or the ones.
did you analyze the data or
Yes,
it is just
yes,
your
yes.
space?
The demographic
Because it
data
is
was analyzed. Was
but it
analyzed.
is not given here anywhere.
No, sir, it is not given here. It is not given here. But as since a chunk of the
Actually,
population was with low education, so we have said
because
that early sensitization.
recommendation is usually based on the result that you get.
Yes, sir. Yes, sir.
Mm. And also you are saying that majority adhere to the recommendation of IFA. That means they were educated they well enough to
Sir,
take the
it is.
IFA tablet.
No, sir. It is not about education. The sub centers here. There was a program in the state in which they actually went inside to the rural areas, and the ASHA workers did a fantastic job. They did door to door survey, and it was not like since they were educated they took the drug, but they were made aware of it, and even the uneducated some of them did. But when we did it on the analysis showed that as the education increased, the success rate was also higher. So we said that
Did you take the hemoglobin level at regular
yes,
intervals?
we did the sign met hemoglobin method, sir.
Was it increasing? Compliance was there?
Sir, from the side of the I mean the people.
Yeah, when you did sign a hemoglobin method, HB level was increasing, or there was a static?
I mean, in the entire population, sir?
Yeah, in the study sample.
In the study sample, I mean, as I said that the hemoglobin level was comparatively lower in the first trimester compared to the second trimester. There was a steady increase in the second trimester, which so this is what we found.
But you have not mentioned anything about the hemoglobin level.
So I have mentioned that if you can see the bar diagram, you can see that I have mentioned just mild, moderate, and severe anemia, and I have given ranges because I did not even find much space to give the entire data, but I have given the range. You can see that moderate anemia from 7 to 8.9. I've written there. That is the hemoglobin range I've set. So we have basically divided into mild and moderate anemia. We did not give the particular values of the anemia. We were seeing that whether what WHO has said that normally there is higher anemia in the second trimester, is it the same in this population, or there is some, I mean, good stuff to look ahead after the intervention.
Right.
Debusmita, what was the rate in your study or the non-response rate?
Pardon, ma'am?
What was the non-response rate or the response rate in your study?
Ma'am, regarding the iron folic acid supplementation, ma'am, non-response rate, if you say, can you please, I mean, response rate from the side of the subjects?
Yes.
No, ma'am, this study was done actually the 10 villages that you saw. We did the study each in one village, and on the day of the antenatal checkup, all the mothers were brought with the help of the ashas in that particular village. None were left out.
Okay. So Sir had asked you a question about sample size calculation.
Yes.
In your results, could you have mentioned something that
Yes.
would give us an idea of whether your sample size was adequate or not, and what is that measure that you could have reported that you have not reported?
No, ma'am, I won't be able to help you with that. Thank you.
No, but the question is, what could have given us an idea of the sample size?
Given us an idea of the sample size that was required, you mean?
No, of whether your sample was adequate or not. Is there a measure that you could have reported with the results? What is that measure?
Ma'am, if there is a definite answer to that, I don't know.
Okay, have you heard of something called confidence interval?
Yes, ma'am. Yes, ma'am.
Did you calculate a confidence interval for your study?
Okay. And ma'am, I don't know here really. Sample size, ma'am, sample size or the sampling technique, I was not in depth in relation to it. I was there throughout the work, but I am sorry to say this is also a deficiency in my part. I cannot help you with the sampling part right now.
Okay, thank you.
Thank you, Debosmita, for your presentations. I just have only one query. How did you validated your hemoglobin estimations, and have that been accounted for in your corrected prevalence?
Okay, the hemoglobin, sir, we conducted the ScienMet hemoglobin method.
And what is the sensitivity and specificity for that?
The sensitivity and specificity for that, sir, we collected the blood from the rural area, as I said, and then we took it in by following on the transport method. We transported it to the local medical college with whose collaboration we work, and the biochemistry department conducted the entire biochemical study.
So what is the sensitivity and is it a gold standard, or is it some test which has to be validated against the gold standard?
If I think it runs on the photometric principle. As far as basics I've studied of cyanide hemoglobin, it runs on the photometric principles. There is a reagent with diluent with which the blood is mixed, and then it is compared with the photometric standard.
Okay, thank you.
Thank you.
Last, should we move to the last participant, Dr. Manish Bhatt?
Yes, ma'am.
Dr. Bhatt, please share your screen.
Dr. Manish, why did you take this KAP study?
Sir, we just want to know the knowledge of the mothers regarding what are the current practices they are doing in our area.
You have taken data analysis only for 0 to 6 months.
Yes, sir.
Why, what make you try? Because you are asking about exclusive breastfeeding.
Yes, sir. I have asked about the exclusive breastfeeding.
But the sample is participants, eligible participants include only 0 to 6 months.
Yes, sir. We have taken only 0 to 6. Actually, sir, it is a part of a study.
Exclusive breastfeeding is done up to 6 months, no age.
Yes, yes, sir. 6 months.
You should have taken the data from 12 to 23 months. That would have been given better indication.
Yes, sir.
So how did you do this last part? Mother's education, illiterate, primary, middle, high school, intermediate, and found chi-square to be significant. Which were the factors which was more towards this initiation of breastfeeding? What type
Yes,
of analysis did you do?
So we have taken the so we have to do the chi-square test, sir.
What chi-square test?
We have taken.
But how can you say from chi-square test?
So because for for the non-parametric variables, we have taken.
Did you see? Did you see that the distribution was normal or not normal?
So for this, we have to do some.
And for chi-square test, you're seeing that within 1 hour 4, less than 24 hours 3. So this chi-square value is it acceptable?
Sorry, sir, I cannot explain, sir.
How did you arrive at this sample size?
Sir, actually, we have taken the data from the NFHS4, the rural and urban area of the Nainital. The prevalence was just 6.9 and 9.5 respectively for rural and urban. So we have taken the Z square P cube by D square, sir. For this formula, we have taken the total 339 sample size in our area.
What precision has you taken?
So we have divided the area into 2 parts. So first USTC and RSTC, and we have compared with the NFHS data, and they have just give us about the rural and urban prevalence. And we, according to our convenience, we have divided only 2 areas. We have chosen only 2 areas.
You are seeing that only 41.6% of baby are breastfed within an hour.
Yes, sir.
54.9% are exclusive breastfed.
Yes, sir.
So what made you arrive at this sample size?
We have not taken this because, sir, this is the problem in our population, sir. The UNICEF told us that 41.6% babies are breastfeeded within an hour of being born, and so we have tried to rule out the current practices which were doing our area.
And in the ones I am seeing in that 0 to 6 age group, you're asking about the types of feeding: only breast milk, plain water, infant formula. That's why I think that age could have been from 12 to 23 months. That would give a better
Yes, sir.
implication. Okay. Thank you.
Thank you, sir.
Manish, thank you for your presentation. So you mentioned two p-values on poster. So could you please just state the null hypothesis for both of these p-values and interpret that p-value with respect to that null hypothesis? Thank you.
Ma'am, the association of early initiation of breastfeeding with mother's characteristic like mode of delivery and mother's education were found statistically significant.
Hello, any more questions?
Yeah, I have one question.
Yes,
Thank
sir.
you, Dr. Manish. How good your study findings are collaborating with the Comprehensive National Nutrition Survey of India 2016-18?
Sir,
We do have a prevalence of exclusive breastfeedings and in National Comprehensive National Nutrition Survey of India. So how good your findings are collaborating with that findings? And if there is a difference, what could be the reasons for that?
in our discussions, we have not mentioned we have not compared with the NFHS4, but we have compared with another studies which were taken from Andhra Pradesh and some study taken from Nepal. So we have just compared from with that study, sir.
I have one final questions. What do you think are the strengths and limitations of your study?
Sir, the strength of our study was that we have taken the in taken this sample size the age between 0 to 23 months. So this is a crucial time of for the children. So if the malnourishment was found at that age group, then it will become another complication in the later age group. So, and the limitation was that we have we have done this study in a small area and taken the very small sample size. So there is no generalizability.
Okay. Yeah.
Thank you, sir.
Thank you.
Thank you, sir.
Any more questions from a respected chairperson?
Thank you all for your support and cooperation. Thank you so much,
No,
sir.
you can start.
Yeah.
Thank you. So I would like to conclude the session. I would request all our respected chairpersons, if you want, you can again reevaluate and give the markings to the respective participants. And we have in the chat box, we have put in all the detail IDs of ID numbers of the participants. So if you want, you can recheck that. Any questions from anybody? I would really like to thank Ashok sir, Manya ma'am, and Rajamurthy sir for taking out a valuable time from the busy schedule to be a part of this session. Thank you, sir. Thank you, ma'am. So I, Dr. Gaurika Saxena, conclude the session and hand it over to Miss Disha Arora, who will be handling the next poster session. Thank you and have a good day.
Thank you, Dr.
Thank you.
Gaurika.
Thank you.
be okay for those.
A very good afternoon, all of you. Am I audible to all?
Yes, Diksha.
Okay. A very good afternoon to respected eminent speakers and chairpersons. I welcome you all to the annual National Conference of Epidemiological Foundation of India, AIMS Rishikesh. First of all, I would like to welcome all the chairpersons. I'll be your moderator for this session. My name is Diksha Arora and I have completed my Master's in Psychiatry Nursing from AIMS Rishikesh. I have received gold medal in my postgraduate and certificate of honor in undergraduate course with a best research paper presentation. Now I would like to welcome the indeed eminent speaker, Dr. Ratan Kumar Srivastav, sir. Sir is Professor and Head, Community Medicine from Prasad Institute of Medical Sciences, Lucknow. Sir has been a former coordinator of this Regional Resource Center and Telemedicine, IMS, PSU. Sir was the past National President of Indian Association of Preventive and Social Medicine and also the past Secretary General of Indian Sir, research methodology, data handling, family welfare, IC control, leptospirosis control. Then Sir has been the national trainer of IMNCI program and integrated disease surveillance program. Sir has been a national observer of certificate course in evidence-based diabetes management. Sir in total has teaching experience of more than 40 years and guided many MD and PhD students. A warm welcome to you, sir.
Thank you.
Next chairperson with us we have is Dr. Smita Sthana. Ma'am is MD in Community Medicine and is currently working with ICMR National Institute of Cancer Prevention and Research, Noida as scientist and having 16 years of working experience in cancer epidemiology and biostatistics. Ma'am is a course coordinator of Biostatistics and Epidemiology Training Center. Ma'am is a principal investigator of population-based cancer registry project for JP Nagar, Noida. Ma'am has received several awards for the best work in cancer research. Ma'am is having more than 50 publications in reputed medical journals, both national and international. We extend our heartiest welcome to you, ma'am.
Thank you very much.
Next eminent speaker, chairperson with us, we have is Dr. Bhavna Sahani from Department of Community Medicine, GMC Jammu. Ma'am is a public health specialist with 10 years of academic and research experience, working as assistant professor in the Department of Community Medicine, GMC Jammu. Her academic interests include constant upgradation of knowledge through post-PG courses in epidemiology, research methodology, public health, nutrition, etc. Her research interests include tuberculosis, cancer, epidemiology, nutrition, maternal and child health, pediatrics, infectious diseases. Ma'am has hands-on experience as co-investigator in conducting clinical trials of vaccines. Ma'am has also authored 2 chapters in PGD MCH program offered by IGNO and has regular publications in various index journals of national and international repute. We extend a heartiest welcome to all the chairpersons.
Yes, ma'am. Yes.
Now, beginning with our poster presentation, we have with us Dr. Wasifa Parveen. I request Dr. Wasifa.
Dr. Diksha,
Okay, I'm sharing
I
the
have one
screen
query.
if you can see that.
Dr. Diksha,
Yes, sir. Yes, sir.
can you listen me?
Yes, sir. Yes, sir. I can hear you.
Yeah, regarding evaluation, I use Google Form.
Yes, sir. Yes, sir. So we'll
So,
be sharing the
I get
IDs as
those
well.
Google Form.
Yes, sir.
If you can share on my mobile WhatsApp link.
Okay, sir. I'll WhatsApp the link, sir.
Okay.
Okay, sir.
That's it.
Okay, thank you. Dr. Wasifa, can you please continue and present your paper, please?
Diksha, excuse me.
Yes, ma'am.
Diksha, there is lot of background noise, so we are not able to
Okay, okay, ma'am. I'll
request
just.
everyone to please keep them whosoever is not speaking on mute.
Okay, yes, ma'am. I request all the participants to please keep yourself on mute. I'll just mute myself, ma'am, then I think it will be better. Dr. Wasifa, can you please start the presentation? Dr. Wasifa, can you hear me?
Hello,
Hello?
hello. Can you hear my voice?
Yes, yes, I can hear your voice.
Okay.
There is voice in the background. Yes, now it has stopped.
Dr. Wasifa, you can start presenting. The timer has begun.
Okay, my poster is not there. Like, should I have to upload or hello?
Hello? Yes, ma'am. Can you see the poster now, Dr. Wasifa?
Wait. Yes,
Yes,
ma'am.
ma'am.
Diksha.
Your voice is properly visible. Okay, okay.
I
Now
got.
you may begin.
Hello.
Dr. Wasifa, you may start presenting.
Okay, sure.
Yes, thank you.
Yeah. Hello. Hello.
Yes, it is audible, ma'am.
Hello, go ahead, please.
Hello.
Yes, ma'am, you're audible. Please start presenting.
Okay. So my work is on glucose phosphate dehydrogenase deficiency among the ethnic tribes of Upper Assam. Yeah. Hello. My voice is not audible now. Hello.
Your voice is audible,
Is
ma'am.
it
You may continue, please.
is it okay?
Yes, yes, it is. Dr. Wasifa,
Yes.
ma'am, please start presenting.
Okay. My work is on prevalence of glucose 6 phosphate dehydrogenase deficiency among the ethnic tribes of Upper Assam, and we are looking for the identification of variants using molecular methods. So, glucose 6 phosphate dehydrogenase is a cytosolic enzyme and it is the first enzyme of the pentose phosphate pathway. Its main role is the production of NADP, reduced form of NADPH, and this NADPH has a crucial role in preventing oxidative damage to proteins and to other molecules in all the cells. So individual with this disease, with this deficiency, may exhibit hemolytic anemia on consumption of sulfur drugs like chloroquine, primaquine, etc. So our main objectives was to study the prevalence of G6PD deficiency among the ethnic tribes of Upper Assam, and to study the prevalence of this deficiency and associated mutation pattern in malaria endemic and non-endemic zones. Also, to study the earlier history on occurrence of anemia on consumption of specific food or drugs among the study subjects. Some we have set a methodology. First, we have to collect samples, that is whole blood samples, and first we'll go for manual screening. Then this manual screening, we will go for DPIP tests and enzyme kinetics. So those deficient samples will be collected and extraction of DNA will be done. And then we will check the genetic polymorphism by ARMS PCR technique. So out of we have collected 1,001 samples, and we have found 46 deficient samples. And out of this 46 deficient samples, we have found 34 males and 12 females. And this prevalence of G6PD deficiency is varied from 1.5% to 73% in different ethnic groups, with an overall prevalence rate of 4.6%. So there is no specific information. Information was found in occurrence of anemia about after consumption of specific food or drug. We have not found any such subjects regarding this anemia after consumption of drugs or any food. So G6PD deficient, the mean age was 44.02, and with normal is 43.9. Hello?
Yes, ma'am, you're audible. You can continue. You have 1 minute left, ma'am, for the presentation.
Okay. So we have showed the distribution of the deficient samples in pie chart and the statistical representation of screen population among the different ethnic groups that we have collected. We have in our samples this Ahom ethnic group, Deori, tea garden laborers, missing, Pochari, Rajbangshi, and Muslims. So we have a highest prevalence rate of the dairies with a 27.7% prevalence of this deficiency, whereas in the tea garden laborers we have 1.4%. So now to conclude, we have actually checked for 3 genetic polymorphism, that is G6PD Mediterranean, G6PD Orissa, and G6PD Kerala Kailan. We have found G6PD Kerala Kailan in all the study subjects, and Mediterranean and Orissa could not be found. Basically, in our findings, we have took a very small number of subjects. So if we are not being able to take.
Sorry to interrupt you, ma'am, Dr. Vasifa. The time limit has gone up. Thank you so much. Now, next, may I please call upon? Any questions? Next one, may I please call upon Dr. Santhil Amudan to start presenting. Please share your screen, sir.
Can we have question with Diksha?
Yes, sir. Yes, sir. Sure, sir.
Diksha,
Yes, sir.
what are the advantage to the community after your study? Is there any advantage to the community?
Dr. Wasifa, please
Yes.
reply to the question.
May I have the question, please?
Means for after completing your study, is
Advantage to the community.
community? Yes.
Actually, we will know about the before treating a malaria patient. We will know about we should check for the G6PD deficiency first. After that, we can uh, go for further treatment. Because if we give them those treatment with pramoquinine or chloroquine, they may have some anemia, hemolytic anemia, or all this kind of things may happen, and there may be some kind of like this bilirubin may goes up or like that.
Okay, okay. But it is known to all of us that there may be G6PD deficiency and primaquine may create problem. So why is it means the proportion is very high of G6PD deficiency in Assam?
Yeah, it's high among the tribal groups actually.
Okay, okay, okay. Over to another presentation.
Yeah. Okay,
Uh,
thank you, sir.
Any more questions from our chairpersons? You may please ask, because thereafter you may please fill them the Google form which has been sent to you.
Deepa, I would just like to make a comment.
Yes, ma'am.
Yeah, Dr. Wasifa, I think it is a very good practice that whenever you present the results, you should always present the 95% confidence interval for the prevalence. It's a good practice, just a suggestion.
The
Dr. Yeah.
statistics, ma'am. Hello,
Yeah, Dr. Wasifa, can you hear me?
ma'am.
Yeah, Dr. Wasifa, I just need to make a suggestion that whenever you are presenting the prevalence, it is a very good practice to write the 95% confidence interval. You can make that change whenever
Yeah,
you
that's a
schedule
lacuna
for
from my side,
publication.
ma'am. I'm sorry.
It's fine. That's fine. Absolutely fine.
Well, I need to improve.
Yeah. Thank you. Thank you.
Thank you, ma'am.
Okay, thank you so much, Dr. Wasifa and Dr. Bhavna. Now, I just wanted to mention that the registration ID for Dr. Wasifa is 100. Please kindly fill in the Google Forms for the evaluation. And meanwhile, let's move on to the next presentation. Now, may I please welcome Dr. Senthil Amudan for the presentation. Please share your screen, sir.
how can I get this Google form?
Sir, we have shared you the Google Forms in the mail ID or we have WhatsApp you the Google Form link. Only the chairperson.
Of yours?
Chairpersons can evaluate.
WhatsApp ID of Diksha Arora or
So I have WhatsApp you the registration ID of our first presenter, Dr. Wasifa, is 100. You can fill in there 100 and thereafter you can evaluate them.
So for that, we need to go back to the Google Doc form and then we need to rejoin.
No, ma'am, it's okay, ma'am. You can note down the points and you can fill in the evaluation
Okay.
form at the
Later
end.
on
That's
also
not
we
an
can
issue.
fill.
Yes, yes, ma'am.
Later
No
on
problem.
also we can. Okay.
okay,
Yes,
that is good. That is good.
okay, sir.
Okay, okay.
Dr. Senthil, sir, please continue.
So who is next presenter? Dr. Senthil.
Sir, am I visible?
Yes, Dr. Senthil, go ahead.
Okay. So very good afternoon to all. I am Dr. Sendil, Additional Professor, Department of Epidemiology, NIMHANS, Bangalore. Today I am presenting the e-poster on epidemiology and burden of suicide death in India. Emphasizing the facts that suicides are preventable, there is a hope, and it is a global health concerns. Our background or rationale of the study has been placed on the following arguments. Suicide is a serious public health concern globally. Suicide knows no boundaries. Suicides is the one among the 20 leading causes of death worldwide, and second leading cause of death in young people aged 15 to 29 years of age. It is said that every 40 seconds someone dies by suicides. So what do suicides in India have for global relevance? Suicide is also one of the leading cause of mortality in India. India, with a large population size of 1.3 billion, accounts for 18% of global populations, and India is yet to develop a systematic response for suicide through a national suicide prevention strategies. Thus, suicides in India have got global implications towards SDG targets 3.4. For any country, suicide preventions in any countries requires a good epidemiological understanding of prevalence and distributions of suicides. With robust data available from Global Burden of Disease study, there is an immense scope for translating the information data into useful information for public health actions. With this in background, we did a systematic analysis of epidemiology and burden of suicide in India using deaths and years of life lost from Global Burden of Disease data. Coming to the methodology, we used data of all-cause mortality for India in 2017 from Global Burden of Disease data. We did an analysis on epidemiology and burden using a comparison and analysis for the following descriptive statistics that range from deaths, years of life lost, decadal trends, gender and age differentials, and state differentials. The raw data from the Global Burden of Disease were transferred to Excel sheets and were analyzed using Stata version 16 for deriving meaningful interpretations and illustrations. We also have used QGIS software for spatial data analysis. Coming to the results, India accounted for 1.83 lakh deaths in suicide deaths in 2017. Strikingly, India accounted for more than 1/4 of total global years of life lost that were attributable to suicides, and nearly 1/4 of global suicide deaths were attributed to India. This clearly indicates India as a significant contributor of global suicidal burden. Now, moving further to the epidemiology, the suicide rates, taking the suicide death rates, India recorded a suicide death rate of 13.93 per lakh populations in 2017. However, the national level estimates were found to mask the large variations that exist for suicide deaths across the states in India. There was a tenfold variations across in suicide rates across the states, ranging from 2.76 per lakh populations in Nagaland to 29.55 per lakh populations in Karnataka. These variations could be attributed to differences in the levels of urbanizations, levels of literacy, levels of employment, difference in access to means, difference in access to the alcohol consumptions, and difference in access to healthcare, and the social cultural factors that were relevant to these states. These findings clearly highlight the need for a comprehensive national suicide prevention strategies that need to accommodate the contextual factors that are specific for the state data. Moving to the age differentials, the state, when one look at the suicide death rate across the different age groups, one can see a typical bimodal pattern with a peak in with initial peak in 20 to 24 years of age and a subsequent peak in 80 plus years of age. This clearly highlights the heterogeneity of contextual factors that attribute to suicide factors across different age groups, and calls for a life course perspective in suicide preventions to target various age groups in different settings, ranging from schools, colleges, and workplaces. When we look at the strikingly, when we look at the pattern across the genders, typically strikingly, women has a higher rate till 20 to 24 years of age. After that, there was an increased raise in the males. In both the groups, typical bimodal peak was seen after 80 years of age, clearly demanding the need to strengthen the suicide prevention strategies in the national healthcare program for elderly. Coming to specifically for the gender differentials, there exist gender differentials with higher rates of higher suicide death rates and higher suicide related years of life lost among men when compared to females. The same thing also has repeated in years of life lost. Summarizing the findings, India is a significant contributor of global burden, highlighting the need for international collaborations and a comprehensive national suicide prevention strategies. The state variations calls for the need to have implementation actions at the state levels informed by the state-specific data, and there is a need for a gender-focused and age-focused multi-sector approach to address the suicide death rate in India. Coming to the conclusions, a national suicide prevention strategy that is comprehensive using multi-sectoral approach is required to account for these differentials and state variations for reducing suicide deaths in India. More importantly, there is an abundance of data that is available from global burden of disease that needs to be converted into useful information for public health actions.
Thank you so much, sir. Thank you so much, Dr. Senthil. Thank you for enlightening us. Now, any questions from our respected chairpersons, please?
First of all, I would like to congratulate Dr. Senthil. So he has taken a very burning and very, very relevant topic.
Thank you,
And I just wanted to know whether you try to compare your data with any other country or global existing data, anything like that you have done?
But we have compared with the global data. We actually thought of comparing with developed countries and developing countries also, but because of due to paucity of space, I could not put that in the poster presentation, ma'am. But we did analysis on global level, developing countries and developed countries. These were our three main comparisons that we made for initial study.
With global comparison, just for the sake of knowledge, what was, whether it was lesser or your analysis found it as comparable or a higher burden over here in India?
Ma'am, India alone contributes for nearly 24% of global suicidal deaths. That's one thing. The gender gap that exists for at the global level has actually got reduced when it comes for India. There was a twofold increase in rates of suicide deaths and OLS as far as men and women is concerned, with men having 2 times higher rate than males. But when it comes for India, that gap has been reduced. It was nearly 0.8 or 0.99 times. So this clearly shows that the gender gap is actually reducing in India, which actually highlights that we need to focus on the women suicide preventions in India to have a global impact.
Okay. Rather, I would say that societal rate in both should be decreased, no? Because you say that you are saying that in men the rates are higher as compared to women.
Yes, ma'am. Actually, at the global level, males have 2 times higher rates when compared to women. But in case of India, that two times gap was not seen.
Okay, good. Thank you.
Thank you, sir. Thank you, ma'am. Any other question? Any more questions you may please ask?
Dr. Senthil.
Yes, sir.
I'm interested that whether you have calculated the death rates between states. Have you compared?
Yes, sir, we have compared the death rates across the states. The lowest state was in Nagaland, which accounted for 2.7 per lakh populations. Highest was recorded in Karnataka, which is 29.55 per lakh populations. And the countries were being coded as per the colors because we thought that it will be too crowded. That's why we didn't put that estimates in the poster, sir.
Okay, thank you, Senthil. Really very good presentation.
Thank you, sir. Thank you, sir.
Okay, now I would just like to mention the registration ID of Dr. Senthil is 55. Respected chairpersons, please note 55 is the registration ID. Now maybe please move on to the next. Okay, now may I please welcome Dr. Dishaditi for the poster presentation. Please share your screen. You will be given a time limit of 5 minutes, so please adhere to the timing.
Very good afternoon to one and all. I am Darshadi Kumar from School of Public Health. Our team consists of Dr. Alex Joseph, Kalpana Kosalram and Roshni Mary Peter, on epidemiologist and 2 doctors about systematic review on burden of co-infection of hepatitis viral infection in India, epidemiological studies which have been conducted during the year of 2008-2018. And the study states that viral hepatitis is a global epidemic concern, and viral hepatitis is a silent epidemic, and many of them didn't notice. Even the public health workers has lesser knowledge on hepatitis viral infection. So strengthening of our health system is a very important need. That's the rationale of our study and systematic review. And it is a part of large scale project which has been funded by ICMR. The global scenario, hepatitis A and E is the usual and acute cancer hepatitis, and the hepatitis may cause cirrhosis of liver and hepatomegaly, which will morbidity. And hepatitis C and B are the highest contributor of death rates, especially hepatitis C. And then moving to WHO estimates, worldwide hepatitis A caused approximately 11,000 deaths in 2015. That is a recent data. I mean, 2015 is the data. And then Southeast Asia region, because India belongs to Southeast Asia, we have taken a Southeast Asia. 100 million population are living with hepatitis B viral infection. As I said before, hepatitis B and C combination. We taken the comorbid condition, I mean coexisting dual burden of hepatitis B viral. Either the inclusion criteria for selecting study has been co-infection. Either the study has to be have hepatitis A and B, or else B and C, hepatitis B and D, like that. It has to be have at least 2 hepatitis viral infection. And the most of the study has been hospital based. Prisma guidelines was used to formulate the systematic review, and was used to select the study designs and select the study. And the publication bias were minimized or assessed by using the subgroup analysis, and then heterogeneity was assessed. And then each study was separately assessed by doctors for selection of each studies. The screening of study, eligibility of the study has been included. The method is we have used, and you can able to see literature sources are from. These are the mestem which has been used from the Cochrane review, and the websites we have included is other open access journals also included. And the study population is and our study results summarize that. Only summarization of result we have included our study because of the poster e-poster. And we retrieved nearly 8 full research paper, which has been approximately included 1 lakh population. And overall prevalence of hepatitis A ranges from 2.3 to 52.5, and overall prevalence of hepatitis B is HPV ranges from 2.85 to 2.27.5, and hepatitis C ranges from 0.5 to 44.6, and HEV hepatitis E ranges from 44. And HEV studied in only one study, that is why it didn't give the ranges. And most of the children were affected by HAV, and the many studies have correlated HPV and HAV, HPV and HCV. Hepatitis C viral and hepatitis B is a coexisting condition, and it is caused by the determinant of hepatitis B viral infection is syringing and blood transfusion, and then frequent sexual practice also major contributing in the hepatitis B viral infection. And it is a iceberg phenomena. We didn't know the real truth depth of the hepatitis infection, viral infection. And India has taken so many steps to prevent the hepatitis viral infection. Even though hepatitis is a huge contributing huge number of death, even though free vaccination available for the certain criteria of people, still it is highly prevalent. It stays as a epidemic, and it is a potential risk for epidemic as well as the outbreak. And our studies, there is a potential risk of reporting bias due to the over-reporting or under-reporting of the selected studies. Yes, sir, even though selected studies, our study conclude that the serological prevalence of hepatitis C was found in male, and global report states that by screening and treatment in the hepatitis B viral, eliminate the hepatitis B viral infection because it's contributing the highest rate of death and morbidity. And as a result of majority are risk of chronic liver disease and cancer. It is a public health threat. Due to the Sustainable Development Goal 3, we are obtained to achieve the also we need to reduce the burden of hepatitis viral infection in Indian region, because we are contributing almost 1.16.
Thank you so much, ma'am. Thank you for your presentation. Any questions from our chairpersons? Please, you may ask.
Hello?
Yes, ma'am.
Is your this systematic review is registered in any of the Prospero, because this is an epidemiological study? So is this
Yes, ma'am.
registered in
It
Prospero?
has been registered under the Prospero. It's under the review. Still, they didn't give the further approval, and we are waiting for the approval under the Prospero,
So
ma'am.
once
It is registered actually.
now once you have started, then they will most probably, because once you start the study, they say like it's like a clinical trial. Once you go and register for clinical trial, they, even if you start enrolling few patients, 2-3 patients, they say now we can't register that. Similarly, in Prospero and other these sites, they also don't register once you start working on the subjects. So it's difficult,
Yes,
but
ma'am.
you can try.
Yes, ma'am. I have tried 2 times, and first time we got that apologies letter from Prospero because it looked like a narrative review, any effect and intention. So you can go search there. And if we are doing further meta analysis in Revman 5, they said that if you're finding so many new like a new result or something else correlation between some other variables, then you can register as a subject for further research.
How many investigators?
Hepatitis B or C. Two reviewer has been
Voice is
finalized the study. Two has been collected data from various platforms, and finally duplicates has been removed by using the Prisma guidelines. Like we have removed duplicates, and we have we have screened our data thoroughly and then identified from the data excluded for the statute will be different and reference question will be different from ours. Those kind of data has been removed and removed. And finally, we have included 8 data which studied the dual burden of hepatitis infection, viral hepatitis.
My last question is whether you applied Prisma checklist or not.
Yes, ma'am. I have applied it. I have applied it.
Okay. Thank you.
Thank you, ma'am. If you want, I'd like to share that screen. You can see, ma'am, and it will be due to the online presentation. I think I couldn't able to show it clearly,
That's
but
okay. That's
still I
okay.
can
You are
zoom it
telling
and
in. We agree to that.
Thank you so much, ma'am. Any more questions from Dr. Disharati you want to ask? And please keep sharing the screen until all the questions have been completed. So I think that would be
Sure,
easy.
ma'am. Sure.
Yeah, thank you. Any questions from chairperson, please? Okay, so shall we move on to the next poster? With your permission, ma'am and sir. Okay, so I would like to welcome Dr. Aman Rashid to please share your screen and present your poster, please.
Diksha, but you have not told us the ID.
Yes, yes, sorry, ma'am.
Registration.
Yes, ma'am. Registration ID for the charity case 49.
49.
Yes, ma'am. 49.
49. Okay.
Yes, ma'am. 49. Now, next is Dr. Eman Rashid.
Yes,
Please
ma'am.
share your poster.
Yes, ma'am. I'm sharing. Ma'am, I'm not able to share my poster.
So, okay, wait a minute. I'll share the screen for you.
Yeah, ma'am.
Can you see it?
Yeah, ma'am.
Yes. Okay, please
No,
start.
ma'am. Yeah, okay, ma'am. Okay, okay.
Is it visible to
Am
all?
I audible?
Please start presenting. Yes, you are audible.
Okay,
Please
ma'am.
continue.
Good evening, everybody. My topic for the presentation of poster is epidemiology and molecular diagnosis of high-risk human papilloma virus infection in women patients. So HPV is a major cause of cervical cancer worldwide, and it is known as the most common sexually transmitted infection. It is a double-stranded DNA virus of the family Papillomaviridae, and it is a non-enveloped DNA virus with 8,000 base pairs. Most HPV infections are asymptomatic, unrecognized, or subclinical, and may cause warts, which appear as small fleshy bumps on skin. Most people get infection of HPV through direct sexual contacts. There are several high-risk HPV types, among which type 16 and type 18 are the oncogenic types, causing 70% of all cervical cancer. In our study, we screened 380 patients with suspected HPV infection at a lab that is located in Uttarakhand, and it is a study conducted in the Uttarakhand population. The molecular diagnosis was done using HPV DNA testing by PCR based on amplification, using specific primers to amplify the high risk HPV type 16 and type 18. Um, in our study, the results showed that around the patients were categorized based on the symptoms of abnormal uterine bleeding, pelvic inflammatory disease, and vaginal discharge. These symptoms contributed to a percentage of 22.55%, 18.69%, and 26.70% in premenopausal women, while the other category was of the postmenopausal women, in which the infection was lesser, that is 11.62%, around 2%, and 11% respectively. These results show the higher fraction of infection among the premenopausal women patients. However, the patients which were categorized with other symptoms showed higher risk or higher infection rate, around 74%, which were shown with the symptom of postmenopausal bleeding. Uh, Data based on patient studies showed that there was decrease in pelvic inflammatory disease with increase in age. There are 36% of the PID patients which were of the age group of 20 to 30 years, which reduced to 21.46% in the age group of 41 to 50 years, and merely it was 5.88% in the age group of 50 years and above. Our study also showed that the respective symptoms of AUB, that is abnormal uterine bleeding, PID, and vaginal discharge, are the major symptoms among the uh, premenopausal women, and with 60% positivity with AUB, that is abnormal uterine bleeding, while the percentage was of infection with with vaginal discharge were 20%, and in postmenopausal women, 13.95% patients showed postmenopausal bleeding. In the light of the present study, it was concluded that the rate of infection was found to be associated with the symptoms of AUB, PID, and VD, and type 16 and type 18 patients were most commonly observed. Also, the estimated study also showed that we also did a comparative study with the other states also, which showed that 80% cases of HPV were in less developed countries, and the study conducted in Delhi showed that the high risk HPV type was found in 73% cases, followed by type 18 with 18%, while in 2019 the rate of infection of types 16 was around 95%. Also, in a study conducted, it was shown that in the rural district of Maharashtra, there was prevalence of around 37% of high risk HPV infection. The molecular and the epidemiological study have solidified the association between the high risk strain of HPV and cervical squamous cell carcinoma. The majority of the positive patients also in our study showed that they belong to the poor socio-economic status. Also, uh, hello.
Yes, thank you so much, ma'am.
Yeah.
Any questions from the chairpersons, please?
Yes, Ayman Rashid.
Yes, sir.
Have you seen any effect, whether any women who was vaccinated and then later on you follow after 10 year or 15 year?
Actually, sir, we were not able to do the proper follow up, as we were not able to communicate with the patients. We just did the screening of the patients who were coming for the testing on the basis of their symptoms.
Okay.
We were known about the we were uh, clarified about the symptoms, and they were coming to the lab for the confirmatory tests. So we did screening of those patients on the basis of their symptoms, and we were not able to do the proper follow up due to the
Okay.
restrictions from the hospitals, that doctors were not able to allow us to do the proper communication with the patients.
Okay. Okay, Rashid. Thank
Yes.
you. Thank you.
So, just one comment, Rashid,
Yes, ma'am.
that in your title itself, one thing is like human papilloma virus cervical infection. Cervical word is missing. You somehow missed out. That
Yeah,
is
ma'am.
one suggestion. Then epidemiology word is little bit like you have done in a very small number of like symptomatics only. So epidemiology is a broad term in which you see the lot of
Yeah,
population
yeah, ma'am.
community base and all that. So
We
otherwise, it's
only
a
just
good effort,
screen
you
the.
know.
Yes, ma'am.
You have not cross-checked with means it's a screening test as a screening tool you are using. So have you not taken biopsies and all that from the
We were getting
those
we were getting the cervical brushings, and in some cases pap smears also. So we did the DNA testing of those patients.
but the sensitivity of pap smear is low.
Yes, ma'am. And basically, pap smear
Sensitivity
was.
biopsy, so biopsy confirmation in positive is, I think, suppose I mean to say that
Yes, ma'am.
gynecologist might have not given you data or something like that.
Yes, ma'am. And we were not able to access the proper data, and we were not able to communicate. So this was a major restriction to our study. So
Okay.
that's why I confined my study to lesser patients. So it was just a
Oh.
study conducted in the Uttarakhand population, and basically the patients were coming from low socioeconomic background. So
Yeah, yes.
yeah.
That's a nice effort. Otherwise, but in that case, the title somehow you should use the title of correlation of symptoms, something like that, with the HPV testing, some
Okay,
sort
ma'am.
of that sort of, because the proper whatever is you are doing
Yes,
should
ma'am.
reflect from. There is a lot of mismatch between title. Otherwise, it's at your level, it's a good effort. Thank you
Thank you,
very
ma'am.
much.
Thank you for the suggestion, ma'am.
Uh-huh.
I'll surely keep it in my mind. Thank you so much, ma'am.
Thank you so much, ma'am. Any other question from our respected chairpersons? You may ask, please. The registration number for Aman Rashid ma'am is 46. We have also added that in chat box, the registration number for all the poster
Okay,
participants.
ma'am.
Please
Okay,
see.
ma'am. Thank you. Thank you.
With your
You can
permission,
go
ma'am,
to another candidate.
maybe conclude the session.
Yes.
Okay, I would like to thank our respected chairpersons, Dr. Ratan sir, Dr. Smita ma'am, Dr. Bhavna ma'am. Thank you, ma'am, for
Okay.
joining with us, and thank you to all the poster participants. Looking forward.
Okay, so only four. So now you have to send the link for so that we can put up our comment.
Yes, sir. Yes, sir. We'll share again that on WhatsApp.
Okay, thank you. Thank you,
Okay,
Deep.
thank you
Thank
so
you,
much. Thank
Diksha.
you, all
Thank
of
you, all
you.
the participants.
Thank you,
you so
ma'am.
much,
Best
Deepika.
wishes.
And
Thank you,
thank you,
Deepika.
my colleagues.
Goodbye, everyone.
Thank you. It
Thank
was
you, sir.
nice.
Thank you so much.
It was nice to be
What
with
an
Dr. Smita and Dr. Bhavna. Yes.
Yeah. Thank you
I
so
could
much,
not
sir.
see you. Can
thank
you
you,
Thank
sir.
you,
Dr.
ma'am.
Thank you so much,
Srivastava and
बच्चे.
Dr.
हेलो
Bhavna.
मैम, कैसे
Nice
हो
meeting
आप?
you at
Yeah,
this
same here,
platform.
ma'am.
कैसे
Bye.
हो
Take care, ma'am.
आप?
bye?
Take care, everyone. Thank you.
Thank you so much. Thank you all of you. बहुत miss